Good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. And when I say warm welcome, that's exactly what I mean. A hot welcome from a hot topic. And we were going to be hearing about the voodoo science of endoscopy, but we have something much more interesting. In fact, we have Jocelyn Hellig, who's well known to us. Doesn't need an introduction, but she's certainly going to get one from me. As you know, she is an expert on women's health, and she recently completed the obesity guidelines. We heard recently also talk on the obesity drugs, which are very popular nowadays. She's going to be speaking about help. I have adrenal fatigue, I'm estrogen dominant, and I have Hashimoto's. So this is something that obviously is along the lines of endocrinology. It gives us great pleasure to have you over here. A warm welcome and a happy 2026 to you, Jocelyn. And Jocelyn has given us permission to say that she's a consultant endocrinologist. She's based at the Kingsbury Hospital, and our sponsor tonight is the Pelvic Floor Foundation of South Africa. A warm welcome also to the two other people online. That is Chris, who's our technician and assisting with his slide. And of course, Professor Steve Jeffrey, who is on the other fatigue. I'm estrogen dominant and I have Hashimoto's, and other tales from the far side. Jocelyn Hellig, good evening to you.
Thanks so much for that introduction, Peter, and thank you to the Pelvic Floor Foundation for hosting me again. I really enjoy this particular meeting. And just sort of to the audience, we are happy to take questions during the course of the presentation, because I know sometimes towards the end we may not remember what we wanted to ask. So please post a question in the chat box, and I'm more than happy to answer that as we go along. All right. So this is an excerpt taken from a fantastic column that was written by Alistair McAlpine, who is a pediatric palliative care doctor who used to publish this under the banner Digital Clubbing. And this was from one of his columns in 2018. And I'm going to start off this evening with sharing his thoughts with you, which I thought perfectly encapsulated what we are about to tackle this evening. So the Facebook pages positively glow with patients bearing testimonials to health restored and faith in doctors renewed. Over water coolers, businessmen regale each other with stories of how Stephen in accounting's mother-in-law's back pain, which normal doctors tried unsuccessfully for years to fix, finally met its match at the hands of that new integrative medicine doctor just down the road, who looked into her eyes with that machine from Nepal and told her it was the gluten from the rusks she enjoyed with her tea every morning. Since cutting them out and drinking these special magnesium tablets, she's never felt better. The doctor is expensive, sure, but the treatment she offers are simply unparalleled. Now, integrative practices are springing up all over the country, and many have waiting lists that are weeks long. Patients seem to be happy with the service that they receive and appear to claim real benefit. And certainly many of my patients also see integrative medicine practitioners. This really raised the question for me, what exactly is integrative medicine? Should those of us with an interest in evidence-based medicine be taking it seriously, or should we ignore it altogether? And I have to ask, are there any lessons we can learn from these colleagues? So, according to the South African Society of Integrative Medicine, or SASIM, integrative medicine recognizes the holistic and unique nature of human beings, which encompasses physio-energetic information systems. And I must have missed that lecture at medical school because I have no idea what a physio-energetic information system is. It investigates the
Jocelyn, I can help you there. It's a very energetic physiotherapist. So that's what it, yeah.
Thank you for clarifying that, Peter. It investigates the multifactorial causes of disease And in this approach, the practitioner and the sick individual form a team working towards an integrated protocol of management best suited for that person. The priority is to support health using using the least invasive and the most natural approach. And this does not exclude symptomatic treatment of disease where appropriate. The British Medical Journal has a less verbose definition and states simply that integrative medicine is practicing medicine in a way that selectively incorporates elements of complementary and alternative medicine into comprehensive treatment plans, alongside solidly orthodox methods of diagnosis and treatment. So, what essentially we have here is that integrative medicine is simply a combination of orthodox or allopathic medicine and complementary and alternative medicine. And complementary and alternative medicine is a massive umbrella term incorporating dozens of different treatment modalities. Thus, the ground holding integrative medicine up seems to be shaky, but sadly, it hasn't given way just yet. Now, this brings us to the definition of pseudoscience, because the two...
Okay, now, Jocelyn,
Yes.
if I could just come in over here. I told you, okay, we get a
Sure.
special prize here for the first person who can give me the author of the picture from which this book is extracted. You've got 30 seconds and you win one of those very difficult CPD points. As soon as you give it to me, you get a CPD point of an ethics nature. So please continue, Jocelyn.
Cool. Thanks. So this brings us to the definition of pseudoscience. And pseudoscience is a system of thought or theory that is not formed in a scientific way. And as doctors, we are taught to think in a scientific way. It goes on to define itself as a collection of beliefs, practices, or theories mistakenly regarded as scientific, which are in fact not grounded in science, fact, or evidence. And pseudoscience is an example of a sort of system of beliefs that really relies on things like confirmation bias, for example, which I'm going to explore with you a bit later. Now, examples of pseudoscience started with phrenology, which you can see by the phrenology head over here, and has even extended into conspiracy theories, such as this conspiracy behind fake moon landings. Alternative or integrative medicine is a branch of pseudoscience because it fulfills the definition of a system of beliefs that is not grounded in the scientific method. So it is a step further than phrenology and the conspiracy theories such as fake moon landing. So that is just to set the scene, which is going to form our conversation today. Now, in 2020, the World Health Organization declared a worldwide, what they called infodemic, based on concerns that a global epidemic of misinformation spreading rapidly through social media platforms and outlets poses a serious threat to public health. And unfortunately, integrative medicine and alternative medicine practitioners have been key in terms of spreading the infodemic. Now, there is not one patient who sits in my office and doesn't say to me, Jocelyn, but I saw this on Instagram, or I read this on Facebook, or I follow this woman on TikTok, in terms of relating to their own medical issues. And I'm sure you hear the same from your patients every day. Now, online medical misinformation is key to the infodemic. And sadly, it is not something that is getting better. Now, just to continue with our definitions, because when I was researching this talk, I didn't actually realize that these two were distinct entities. Now, the American Psychological Association defines misinformation as false or inaccurate information, such as getting the facts wrong. But disinformation is false information which is deliberately intended to mislead, which is intentionally misstating the facts. Now, the spread of both misinformation and disinformation has affected our ability to not only improve public health, address climate change, maintain a stable democracy, but also it has made it increasingly difficult for us as clinicians to have rational conversations with our patients and implement appropriate guideline-orientated evidence-based management. Now, some of the key drivers of medical misinformation are the following. Social media platforms such as Facebook, TikTok, Instagram, Twitter, and even WhatsApp are key in terms of the spread of misinformation. And sadly, a lot of this goes largely unchecked by these companies. We've spoken about the infodemic concept. Deliberate disinformation is, for example, spreading harmful messages about vaccines, which is sadly something that we've seen the current USA administration do very, very well. One of my pet hates is the rise of the influencer generation on social media, and sadly, influencers and alternative health promotions have found their feet in spreading medical misinformation and disinformation online. Number one, to promote their own following, and number two, there's largely a financial incentive behind this medical misinformation and disinformation often. Now, we've spoken about the conspiracy theories, and we know that these were particularly rife with COVID-19, for example. And also, I'm sure you've heard from some of your patients about the 5G conspiracy theory. And really, this has become a key driver of medical misinformation. And then, sadly, a lot of people have very low health literacy and have very low trust in the medical community as a whole. And this is something that we've seen intensifying significantly post the COVID-19 epidemic. Now, this was an editorial published in The Lancet in January last year. And just to sort of highlight a statement from here, they said that misinformation and disinformation can no longer be viewed simply as an academic nuisance, but rather as a societal threat. And certainly, again, this is not something that is theoretical. This is something that as clinicians, we are having to wage war against on a daily basis. And I think that some specialties are more prone to misinformation and disinformation than others. And I think particularly when it comes to endocrinology and gynecology, where the focus is often on women and female health, there is a slew of medical misinformation online that is posing a threat not only to the way we practice medicine, but to our patients' health and well-being as well. Now, a famous and well-known example of medical misinformation and medical disinformation is vaccine skepticism. I'm not going to go into this in too much detail because that is not the sort of vaccine skepticism is not the main focus of my talk this evening, but this is really an example of where medical misinformation and disinformation has done an incredible disservice to public health. So we know that a lot of the skepticism started originally with the MMR vaccine, where there was a poorly substantiated claim that it was linked to an increased risk of autism in children. And we've seen this more recently with the COVID-19 vaccination program and with the rise in measles in the USA, where people are deciding against vaccinating their children. Now, COVID-19 I see as a turning point in terms of the way that we practice medicine, particularly when it comes to the amount of medical misinformation and disinformation online about a particular disease, and how patients have lost trust in the healthcare profession. And it is difficult to pinpoint exactly where that tipping point came, but certainly it sort of made a sharp turn during the COVID-19 epidemic, where patients no longer trusted evidence-based advice from their usual healthcare providers and instead turned to sort of TikTok and Facebook to receive advice about curing their COVID-19 with ivermectin or drinking bleach to sort of cure their COVID-19 or the origin of the COVID-19 epidemic. And unfortunately, this made it a very difficult pandemic to combat on a personal level as a doctor, as well as a public health level. Now, we've been speaking about pseudoscience, integrative medicine, and medical misinformation. And I just want to compare that with how most of us were taught in medical school how to practice medicine. And this is based in what we call evidence-based medicine, which I'm sure is a concept that all of you are familiar with. But just to sort of remind you what the definition is here. So evidence-based medicine, or EBM, uses the scientific method to organize and apply current data to improve healthcare decisions. Thus, the best available science is combined with the healthcare professional's clinical experience and the patient's values to arrive at the best medical decision for the patient. So far, this all sounds very reasonable. There are 5 main steps for applying EBM to clinical practice, and these are probably things that we do now without really thinking about them as 5 individual steps. So that's defining a clinically relevant question. For example, would my patient benefit from a GLP-1 receptor agonist to manage their weight? Searching for the best evidence. So we would usually turn to sort of PubMed or UpToDate or sort of the Lancet or the New England Journal of Medicine to look for recently published data. Critically appraising that evidence. So not all evidence is created equal. For example, a small case-controlled study or retrospective study is very different from a double-blinded, randomized, placebo-controlled clinical trial. So when it comes to evidence, there most certainly is a hierarchy. Then applying that evidence. So it seems from the evidence that my patient would be a good candidate for this kind of medication. And then evaluating the performance of evidence-based medicine on a continuous basis. And we always say that we're allowed to change our minds when new science comes to the fore. So this is how we have been taught at medical school. This was a discussion that had formed in the early 90s, and really it has become the foundation in which a lot of us practice and make sound, reasonable, and most importantly, safe decisions regarding patient management. So turning our attention back to misinformation. Now, I am fascinated as to what drives people to believe misinformation. And it's often a conversation I'll have with the patient sitting in front of me. I often ask them, why do you think that statins are bad for you? Or who told you this? Where did you read it? And the answers are often quite similar. So it's interesting to me. It's very interesting to me how people come to believe what they read online. So this is a snippet that I've taken again from the American Psychological Association website, which is really a great resource for medical misinformation. So they've explained some psychological science behind this. And what they tell us is that research on knowledge neglect suggests that it is effortful and difficult for our brains to apply existing knowledge when encountering new information. So when new claims are false but sufficiently reasonable, we learn them as facts. Thus, everyone is susceptible to misinformation to some degree. We acquire it even when we know better, because fact-checking for accuracy is such a difficult cognitive task. These challenges persist whether we are passing the biblical flood or Russian geography, viewing posts about vaccines on our social media feed, hearing about the newest immune system booster from a relative, or watching a television talk show host talk about a new dietary supplement. In this view, health misinformation is simply a specific type of misinformation that will follow the similar rules of knowledge neglect. Now, if you have some time, I highly recommend reading this article that was published in the New Yorker in 2017. And it is something I've turned to again and again when I've been trying to make sense of why our patients believe online misinformation and disinformation. And it's called Why Facts Don't Change Our Mind. And I'm just going to share a snippet of that article with you this evening, but it really is worthwhile going into in some detail. So they speak about sort of two psychological researchers, Mercier and Sperber, and they're speaking here about confirmation bias. But they've retermed it, or they prefer the term my side bias. And they go on to explain that humans aren't randomly credulous. When presented with someone else's argument, we're quite adept at spotting the weaknesses. But almost invariably, the positions we are blind to about are our own. So if we have a look at specific individual factors that may influence susceptibility to misinformation, these include the ability to process abstract information, so those with a higher level of education, analytical reasoning, and numeracy skills are negatively associated with the endorsement of misinformation. However, I have seen in my practice that a lot of highly educated people are still prone to medical misinformation. Individuals who are overconfident in their ability to distinguish between true and false headlines are also more likely to trust or visit untrustworthy websites and share false content. Now, interestingly, when it comes to age as a factor, adults over the age of 65 are more likely than younger adults to share false information on social media. But interestingly, older adults are also better at identifying misinformation and distinguishing between true and false headlines. And this probably has something to do with experience. In the USA in particular, conservatives are more likely than liberals to believe misinformation. And that's certainly something we've seen with the new Trump administration. So how and why does misinformation spread? And this is quite a nice diagram to illustrate it. So exposure to misinformation increases belief. So we start at exposure, and exposure increases belief. This in turn increases sharing, which comes down over here. Exposure can also increase sharing directly without affecting belief. So that's pathway number 3. So you might share some content without necessarily believing that content yourself. We've spoken about psychological risk factors that can increase the likelihood of exposure to misinformation, and these can also impact its effect on belief and sharing. So it's really a multi-directional pathway in terms of how exposure influences belief, which influences sharing. And the risk factors we've spoken about in the previous slide that increase our propensity or susceptibility to both believe and share medical misinformation. Unfortunately, the current USA political administration has not helped our cause. It's headed by RFK Jr., who is notoriously an anti-vaxxer and has chosen very unusual sort of points in his administration to address on a public health platform. These include things like damning seed oils, which are actually good for us, suggesting that women who are pregnant should not take Tylenol because there is a link with autism, And his very sketchy stance on vaccines has increased the number of vaccine skeptics in the US, which has led to multiple measles outbreaks in the past 2 years. So unfortunately, the current political climate does not support evidence-based medicine. So maybe just some helpful pointers to share with your patient if you are going to have this discussion, which I think that we should be having in our consultations. So some red flags to look at with spotting medical misinformation online is someone trying to sell you something? Because if they're trying to sell you a supplement or a weighted vest or a compounded cream, they are probably selling you misinformation as well. Are these people playing on emotion, especially fear or anger? So if it is eliciting a specific emotion in that patient, most likely there is medical misinformation. And then finally, words like breakthrough, miracle, secret, or guaranteed probably mean that what this person is telling you is untrue and not grounded in science. Now, the wellness industry is a hotbed of misinformation, and it relies heavily on sort of vulnerable, susceptible, and desperate individuals. There's a tendency to blame big pharma for a lot of ills with our current medical climate, but you can see that big wellness is not innocent. And in fact, big wellness supersedes big pharma in terms of revenue. And in 2023, the global wellness economy was estimated to have turned over $6.3 trillion. And this included things like traditional and complementary medicines at $550 billion, healthy eating, nutrition, and weight loss, wellness real estate, mental wellness, wellness tourism, physical activity, and personal care and beauty. And it's really important to be aware of this when we are discussing these things with our patients. And for all the pseudoscience and misinformation, with the backlash that has brought to science and evidence-based medicine, I couldn't help but think that this tweet from a couple of years ago, when Twitter was still a thing, was not more appropriate. When Doc Bastard tweeted, "It has taken medical science 200 years to advance humans to the point where people are so healthy and are living so long that they can deny that science and medicine is what got us here." Now, to turn our attention to medical misinformation and pseudoscience in the world of endocrinology and gynecology, and I'm going to touch on a few points that I see in my practice on a daily basis. Now, the wellness economy has sadly been infiltrated by very influential and very powerful people. And one of these is Gwyneth Paltrow, who I think should have stuck to acting instead of selling vagina-scented candles. But we know that her Goop lab and a lot of the things that she's said online when it pertains to mammography, for example, can be particularly damaging to susceptible individuals. Where it becomes a little bit more tricky is when qualified doctors, general practitioners, and specialists straddle the world between some science and some medical misinformation. So a lot of you might be familiar with Mary Claire Haver, who is a well-known menopause expert in the US. And whilst a lot of the things that she says online are scientific, there are a lot of things that she says online that are not. And these are, for example, selling her supplements or selling her weighted vest, which she advocates for every woman who should be exercising, or telling us that menopausal hormonal therapy is for every single postmenopausal woman. So it becomes a little bit challenging for patients when medical misinformation straddles science and is something that is propagated by doctors. Andrew Huberman is another example. We know that he is one of the longevity bros and often has people on his podcast who straddle that fine line between science and medical misinformation. And these kind of people make it particularly tricky for patients and for colleagues as well. So, almost every day, someone will tell me, Jocelyn, it must be my hormones. This is why I'm feeling tired. This is why I'm depressed. This is why my hair is falling out, and this is why I struggle with my weight. And I'm disappointed to tell them, and I feel quite sheepish in telling people that in most cases, it's often not. And I'm going to take you through some common clinical scenarios and questions that I see in my practice on a daily basis. So, this is a referral that I have recently received, and the referral was written by a general practitioner, and it says 40-year-old woman with depleted sex hormones with persistent fatigue and hormonal symptoms. Kindly assist with further management. And the patient herself sent quite a detailed timeline of her medical history. And I just want to sort of draw your attention to specific things here. And it sounds like this is a patient with primary ovarian insufficiency who was diagnosed sort of in her late 30s. But as you can see, she has seen multiple doctors regarding her symptoms. And then eventually, as a lot of patients do, being frustrated with traditional medicine, turn to integrative medicine. And she has been placed on a variety of supplements such as DHEAS, hormone assist, multiple metagenic products, and then her urogestin was replaced with a compounded progesterone. They added some testosterone and they put her on some adrenal support. And over the course of the next few months, she has been on a variety of different compounded preparations, supplements, intravenous infusions, and all of this has not led to her feeling better. And her referral has now landed in my inbox. And this is just one example of patients that I see on a daily basis. So one of the biggest things that we're seeing in the world of medical misinformation is the amount of misinformation spurted online about menopause. And for those of you who don't yet follow her, I would highly recommend following Jen Gunter on Instagram and subscribing to her newsletter because she really is an evidence-based voice in the current climate of menopause disinformation. So this is an article that she wrote in 2024, where she goes into the dangers of medical misinformation online about menopausal hormonal therapy. And she tells us that there has been a rise of social media posts positioning MHT as the elixir of youth, essential for heart and brain health, as well as claims that testosterone replacement is vital for every woman. And those of us who follow evidence-based medicine know that this is not true. She cites an example in her article from Dr. Mary Claire Haver, who I introduced to you on a previous slide if you didn't know her already. And Mary Claire posted this on her Instagram a couple of months ago, where she takes us through the risks and benefits of HRT. And some of the benefits she has said here are things like increase in female leaders, increase in GDP, improved health equity, and women taking control. So really, when doctors start using this kind of language on social media, it's important that we are suspicious and that our patients are suspicious of this. She doesn't go into any of the potential, if somewhat small, risks of MHT, but she does, again, use language that is meant to stir emotion, like anger. When she says that a risk is disrupting the status quo, reduce profit for pharmaceutical and medical device companies, which doesn't really make sense, reduce profit for snake oil salesmen, even though she herself sells multiple supplements, and women taking control. And really, this coming from a gynecologist is potentially harmful to our patients in terms of not informing them adequately on the benefits and risks of MHT. And this is an example of when influencers are using very emotive language and emotive statements to elicit strong responses from their readers. Now, one of the common things that we see online is the support of universal testosterone in postmenopausal women. So there was a guideline published on this a couple of years ago, and it is still current and valid. It was published by the Endocrine Society, and it was called Androgen Therapy in Women, a Reappraisal, an Endocrine Society Clinical Practice Guideline. And they go on to tell us that we recommend against making a diagnosis of androgen deficiency syndrome in healthy women because there is a lack of a well-defined syndrome and data correlating androgen levels with specific symptoms or signs are unavailable currently. So I will have a lot of patients tell me, my doctor did my testosterone levels and they were very low. And my answer to them is that is normal. So there is a gradual decline in testosterone levels from our mid-30s onwards, with no significant decline at menopause. It is normal for us to have low levels of testosterone, and that level has not proved to be correlated with a clinical syndrome. Because of this, there is no evidence from clinical trials to recommend the use of testosterone for infertility, sexual function other than a hyperactive sexual desire disorder, cognitive, cardiovascular, metabolic, or bone health, or general well-being. So really, we should advocate against the routine prescription of testosterone for these specific symptoms, and it should be confined currently to be prescribed for women with a hyperactive sexual arousal disorder. Thankfully, we now have Test-FM available in South Africa, which has been a great asset, but too frequently I see women who have been started on testosterone treatment to replace low levels or just to make them feel better. And currently, the evidence does not support that. So just a reminder as to when we should be testing testosterone. This should not be universally done. So the most important as an endocrinologist is to test testosterone when we suspect an androgen excess. So that is in your patients who have hirsutism, male pattern baldness, acne, or a deep voice. Doing a total testosterone is the biochemical test of choice in helping to confirm a diagnosis of polycystic ovarian syndrome, and before starting and monitoring postmenopausal women on testosterone treatment for safety. So we don't measure the level to tell the patient that it is low. We measure the level before starting treatment to make sure that it is not high, because then we would be concerned about giving additional testosterone. It's really important that we don't check testosterone levels and estrogen levels and progesterone levels in women taking hormonal therapy, whether that is MHT, the oral contraceptive, or testosterone treatment, unless we are monitoring it. So just to remind you, there is no clearly defined syndrome of androgen deficiency in women. Testosterone levels do not correlate with symptoms, and the only role for testosterone replacement in postmenopausal women is with those who have a diagnosis of a hyperactive sexual desire disorder. Just in terms of DHEA, we do not test this in primary care. It is helpful as a localizing test when you have very high levels of testosterone to see whether that problem is ovarian or adrenal in origin, and it should never, ever be replaced.
So, Josh, sorry, can I just ask you? So,
Sure.
a lot of people are using the DHEA's cream vaginally. It's been prescribed quite widely. What are your thoughts on that?
What is it being prescribed for?
The DHEA's cream. They are actually
But
using
what is
it.
it being prescribed for?
Atrophy, I think it would be used maybe in a patient who's got some contraindication to the vaginal estrogens. So I think that's what a lot of people are using. Peter, are you actually using this in some patients? Are you seeing it as well?
Yeah, Steve, we have a huge amount of patients being referred to us, having had a whole host, a bouquet of hormonal assays done. And these are premenopausal women typically. And then they have, from the alternative practitioners, again, a sort of random supply of hormones prescribed. DHES is a common one, and it's for no particular syndromic condition. It's just given for ultimate wellness. So what I'm going to ask is a follow-up question to Jocelyn is, when, if ever, is it indicated that a premenopausal woman, apart from infertility, has hormonal assays performed?
Just to maybe, I'll take that question now, Peter, but I think just to sort of answer Stephen's question. So this is just from the the Endocrine Society androgen guideline, is they recommend against the use of DHEA due to limited data concerning its effectiveness and safety in normal women. I'm not sure about the sort of local vaginal cream, but I would imagine that that is not a preparation that has been subjected to any kind of rigorous safety or efficacy testing. I would imagine it's a compounded preparation.
Yes, it is.
It's not something I'm familiar with, and currently guidelines do not support that. So Peter, just in terms of when hormones should be tested, so in my practice, really that should be confined to women who are amenorrheic or have oligoamenorrhea. So women who have infrequent periods or have stopped having their periods altogether, in that specific group of people, then testing hormonal assays with an FSH and prolactin would be appropriate. If there is sort of in polycystic ovarian syndrome specifically, doing androgen assays would be appropriate, and only sort of your FSH and estrogen if that person is amenorrheic or oligoamenorrheic, but not to assist in a diagnosis of PCOS.
Okay. And we've got a question here on that
mm,
topic, Jocelyn. Lizette White says, Presterone is the prescribed DHEA pessary in the United States. It's not available. Do you have any comment on that? Presterone. Have you heard of it?
No,
Not
I've never
okay.
heard of it. Yeah,
Presterone. Okay.
no, I'm
But
not.
sorry,
I'm
Pete,
not familiar with
on
it.
that point, I think they are reconstituting the DHEAS in some of the compounding pharmacies, and I think a lot of gynecologists are actually using it for patients with atrophy, especially those who are not keen on taking estrogen for whatever reason, maybe because of breast CA. And I think there is some evidence mounting for that, but yeah, I mean, I'm not an expert in this at all. So, but I think
Yeah.
it's quite specifically for the atrophy in the vagina. So I don't think it's related to anything systemic.
Okay.
I
Yeah,
think
it's not something I'm aware of, but certainly systemically, there's absolutely no indication to ever replace it. We don't even replace it in people who have adrenal insufficiency.
Okay,
So
great.
I would steer clear.
Thank you.
Thanks.
Then I've seen this come up frequently with patients, and I'm sure you've heard a similar refrain that your patient has gone to their integrative medicine doctor and been told they are estrogen dominant and they need to balance their hormones. And as I'm sure you know, firstly, we should not be testing hormone levels inappropriately or randomly without a really good indication. And secondly, there is no such thing as being estrogen dominant. This is not a diagnosis that is accepted by Western medicine. And we should really try and steer patients away from internalizing this kind of diagnosis and taking supplements and different remedies to try and balance their hormones. Now, something I hear frequently as an endocrinologist is the diagnosis and often self-diagnosis by patients of adrenal fatigue. I'm not sure if that's something that any of you have heard on your practice. I would imagine you have. Now, I was quite curious to sort of see what the origins of adrenal fatigue were. And it's important that we understand that when it comes to a diagnosis of adrenal fatigue, that it is not a diagnosis that is recognized by Western medicine. And the president of the Endocrine Society has told us that our role here is to be good, active listeners to determine if there's a true medical disorder lurking amongst the complaints. It is very important to take the person seriously, not to brush them off and say there is no such thing as adrenal fatigue, because often these people are suffering from something, so we need to take that suffering seriously. But adrenal fatigue was a term that was coined by a chiropractor called James Wilson. And this is his website, adrenalfatigue.org. And how he explains adrenal fatigue is a group of related signs and symptoms that result when the adrenal glands function below the necessary level. Most commonly associated with prolonged stress, it can arise during or after acute or chronic infections, especially respiratory tract infections such as influenza. And as the name suggests, its chief symptom is fatigue that is not relieved by sleep.
Jocelyn, I wonder if we've lost your slides. Are you still you still sharing your?
Yes, Steve. Yeah, we're good. We're good this
Can
side.
you see?
Yeah, we can see. We're good this side.
On my side. Okay. I don't know the side on my side. It's fine.
You good? Okay.
Yeah.
Cool. So he goes on to explain that adrenal fatigue can wreak havoc with your life. And in more serious cases, the activity of the adrenal glands is so finished that you may have difficulty getting out of bed for more than a few hours a day.
That's me.
Now, adrenal fatigue is a diagnosis that our patients are finding on the internet or being given by alternative practitioners, even though medical science does not recognize this condition. We may be tempted to dismiss our patients' claim of adrenal fatigue, but it is important that we take their symptoms seriously and look for treatable conditions such as thyroid disease or an iron deficiency. Most importantly, we need to steer patients away from taking unregulated supplements and other formulations recommended by alternative practitioners, which at best will burn a hole in their pocket and at worst might actually cause harm. And this is just an example of some of the supplements that a patient sort of displayed on my desk the other day, which she'd recently seen a functional medicine practitioner. Now, I just want to compare this to a true diagnosis of adrenal insufficiency, and that is usually due to Addison's disease or due to tuberculosis. So those patients present with gastrointestinal symptoms, so diarrhea, vomiting, abdominal pain, and the key here is that they've often lost weight and a lot of weight. And patients who have a self-reported diagnosis of adrenal fatigue usually report weight gain. But patients with adrenal insufficiency are really unwell. They've got grumbling GIT symptoms. They may often be in hospital frequently, and they are losing weight. You should only be testing the cortisol when there is a high index of clinical suspicion. And those are symptoms like weight loss, unexplained abdominal symptoms, new hyperpigmentation, so they become hyperpigmented because of high levels of ACTH. Fatigue itself does not merit cortisol testing. You are going to make yourself and your patient confused. As we've said, adrenal fatigue is not a real diagnosis and is not recognized by Western medicine. And if you want to check your patient's cortisol when you suspect the cortisol is low, appropriate biochemical testing should be done when you suspect it to be at its highest, and that is when you're waking up at between 7 and 8. So if you're testing for too little cortisol, test in the morning at between 7 and 8 o'clock, and this should be a fasted sample. And a low or indeterminate level should probably be discussed with your friendly endocrinologist, and that patient should be referred for an ACTH stimulation test. Do not test your cortisol if the patient has been on steroids within the past 6 weeks. It is going to be inaccurate. Now, we often hear from our patients, I must have too much cortisol. I'm super stressed all the time. So I want you to reassure your patients that it is normal and physiological for your cortisol levels to increase within a normal range in the following situations. If you're not sleeping, if you're exercising, if you are working really hard, it is your body's normal response to that kind of situation. This does not mean you have pathological cortisol excess. This just means that your adrenal glands are responding appropriately to a stressful situation. And we manage this not by treating the cortisol level itself, but by addressing the underlying stressor, which is just good lifestyle advice, whether that is running, sleeping well, having a reasonable diet, meditating, or in my case, riding horses.
Oh, I thought you were going to say going to church.
Well, that is my church. So, when does high cortisol become pathological? So, how much is too much? Now, only test again when there is a high level of clinical suspicion. And this is in patients who have really thick, violaceous stretch marks, if they bruise very easily, if they have a proximal myopathy, and if they're plethoric. A buffalo hump and abdominal adiposity are signs of overall increased adiposity and are not specific to true cortisol excess. So do not test cortisol in every patient with a dorsocervical fat pad. Appropriate testing should be done when you suspect the cortisol to be at its lowest. So that's typically at midnight. And please do not do random or early morning cortisol levels if you suspect a cortisol excess, because they are going to be misleading. And again, this is probably something that you should run by your friendly endocrinologist. Any questions about cortisol? Because I know that it's something that comes up frequently.
You know, we often have women that come in for cortisol testing, and this has given us a very good guideline. Thank you so much, Jocelyn.
Pleasure.
Can I just quickly finish off this last thing? Lizette
Sure.
White sent another question. Just to put your mind back to prasterone and DHEA, it's a vaginal pessary for genitourinary syndrome with a menopause for patients not allowed to use estrogen in the USA. It's FDA approved. So that's the last word.
Okay, cool. Thank you.
Last word on
Thanks for that.
prasterone. Thanks,
So I would
Lizette.
imagine that's for vaginal atrophy, but
Yeah.
systemically, no.
No, for vaginal atrophy,
Cool.
topically.
Thanks for that.
So Pete, sorry, just I did get a message from Pete Roos, who, as you all know, is also one of our menopause gurus in South Africa. And he threw a little bit of a side comment about Susan Davis, who's also very widely recognized, and she actually says that it's not really recommended. So but I agree. I think is some fairly decent evidence for this, and if it's FDA approved, I think we can use it. So that's fine.
I bow to Susan Davis.
Okay.
I bow to Susan Davis.
No, so maybe we should get Pete to come and give a talk sometime as well. But yeah, we can continue.
So if I had to see every patient that was referred to me for positive thyroid antibodies, I would be living on my own private island. So I just want to put these antibodies into context. So these are the anti-thyroglobulin and anti-thyroid peroxidase antibodies, and they are very usefully located in the PathCare endocrine thyroid box. So people often tick them off when they're doing thyroid functions. So these antibodies are found in up to 27% of the general population. So you can see your anti-thyroglobulin are found in up to 20% of people, and your
there's normal people, healthy people.
Normal people, the general population.
Okay.
Yeah. And your anti-TPO are found in up to 27% of the general population. Thyroid antibodies do not necessarily by themselves indicate pathology and are really of very little clinical significance. Yes, they are significantly raised in patients with autoimmune hypothyroidism, which we call Hashimoto's thyroiditis, but they are also seen in up to sort of 20 to 30% of the general population. They do not have significance in individuals who are biochemically euthyroid. So if you see a normal TSH, do not do antibodies. They are unhelpful in clinical decision making. They are not harmful to the patient. They just act to confuse both yourself and the patient. So I get a referral about raised thyroid antibodies almost every day in a patient with normal thyroid function, and this just causes confusion and concern. So what you can do is, number one, don't test them. They are unhelpful. The only place they are helpful is in the setting of subclinical hypothyroidism in terms of making a decision about treatment. Number one, don't test them. And number two, if you do see that they're raised and the patient brings this to your attention, reassure them that this is not significant and these are raised in up to 25% of the general population. What I will see commonly in practice is patients who are started on thyroid hormone replacement with normal thyroid functions. So when it comes to the thyroid, normal is normal in terms of TSH. We do not make a diagnosis of thyroid disease based on symptoms. We make a diagnosis based on an elevated TSH for hypothyroidism with a low T4. Whether that TSH, if that TSH is low normal or high normal, it is still normal and does not merit treatment. Do not treat the symptoms of hypothyroidism with thyroid hormone replacement if your patient has a normal TSH and T4. So I can understand that doctors get frustrated with patients because patients will come back repeatedly and say, my hair is falling out, I can't lose weight, and I'm feeling depressed. And thyroid function has been tested multiple times, and in all of those times, the number falls within the normal reference range. But because patients are frustrated and doctors are frustrated, I will often see inappropriate commencement of thyroid hormone replacement. Please refrain from doing this. It is potentially harmful. Now, Ryan Reynolds, before he was cancelled, posted this tweet a couple of years ago, which I thought was hilarious. And he said, people in Los Angeles are deathly afraid of gluten. I swear to God, you could rob a liquor store in the city with a bagel. Now, a lot of my patients with thyroid disease will tell me that they've made significant changes to their diet in terms of cutting out gluten. And I will ask them, but why have you done that? So there is no science behind that. There is no benefit to a gluten-free diet in individuals with thyroid disease who do not have concomitant celiac disease or gluten sensitivity. So we don't recommend making any specific dietary changes for thyroid disease because they are ineffective in moderating thyroid function. So unless your patient has celiac disease, there is absolutely no reason why they can't eat gluten. So this is a woman who I follow on Instagram who's a really fantastic exercise physiologist, and she conveys information in a very simple and easy to digest way. So this is her Instagram handle over here. And one of the common sort of sources of misinformation online is about women's fitness. So what we see are people like Stacey Sims telling women that they should cycle sync, so that they should exercise specifically in a way that correlates with certain times of their cycle. There is absolutely no evidence to support that. So some other misleading fitness claims that were prominent on social media last year is walking with a weighted vest builds muscle and increases bone density. It does not do that. Fasting training doesn't work for women. Women should avoid zone 2. Women must do high load, low rep training. Women need protein 30 minutes post-workout. Declines in estrogen accelerate muscle loss. That again is untrue. Menopause decreases metabolic rate. Jumping exercises are a must for bone. Cortisol is to blame for fat gain and muscle loss, and a calorie deficit does not work for women. These are all examples of medical misinformation and disinformation about women's fitness that has been propagated online. And it's really important that those of us who see women as patients are able to dispel this mythology. Now, people love a supplement, a multivitamin, an omega-3, and a probiotic. There is absolutely no evidence to support the use of these routinely. Sure, if you have a deficiency in vitamin D or vitamin B12, or you are following a particularly strict diet, it is not unreasonable to supplement. But for the general population who follows a reasonably balanced diet, there is no indication for routine multivitamin supplementation. There is also no benefit in terms of taking omega-3 supplementation, and there is increasing evidence to show that it may be potentially harmful, and probiotics should not be taken on a routine basis by the general population. Similarly, with intravenous infusions. So a lot of my patients would tell me that they've just gone for a vitamin drip. And again, my question is why? So I'm sure all of you know that there is absolutely no evidence to support routine vitamin infusions. And vitamins are not inert substances. So these may be potentially harmful. And we know that in the USA a couple of years ago, someone actually died from receiving an intravenous turmeric infusion. So I would really be cautious with counseling my patients that this is something that should be avoided and their money is better spent in the grocery store.
Buying vegetables.
Buying vegetables and a nice bottle of wine. So an increasingly popular drug on social media platforms are peptides. And I'm not sure if that's something that you've all encountered as yet. So peptides are sort of being used to make people look younger, to help them lose weight. And these are not GLP-1 receptor agonists, and to increase strength. But currently, peptides are unregulated. They are not FDA approved. They are untested. And at best, they are a waste of money. And at worst, they are potentially harmful to patients. So currently, I would recommend steering your patients clear of peptides. So just some final thoughts. And again, a tweet when it was still cool to do so. So John Hislop posted, "Dear naturopaths, the following systems cannot be boosted with any known herbs or supplements: the immune one, the thyroid one, the adrenal one, the metabolism one, and all the other ones." So I've told you a lot about people who you should not follow online, but these are some recommendations of people online that I really rate in terms of the content that they produce, which is backed by evidence and science. And they also convey a lot of that in a very easy to understand and digestible way. So the Maintenance Phase podcast, Susan Davis, we've spoken about. The docs who lift are present on Instagram and have a podcast. Another goddess in my eyes is Jen Gunter, who I mentioned at the beginning of the talk. Dr. Lauren Semple, who is a guru on women's fitness, and then Dr. Andrea Love, who's an immunologist. So really, really good sources of medical information. Information. So to end off this evening's talk with on a biblical proportion. So I often in my consultations feel a little bit like David, because in a consulting room, we are one person who has to hold strong against a giant of medical misinformation that is being propagated online in communities at the dinner table and at work. It is very challenging to sort of hold true to science and evidence in every consultation, but I would really like to urge you to do so. Not only does that make us good doctors, but it is also certainly in the best interest of our patients. Thank you so much for your attention. I know we've gone a little bit over time, but I'm very happy to answer any questions if there are.
Thank you very much indeed. Just before I ask Steve to thank you, another question here. Great talk, thank you. Any comments on EDC in sanitary pads? Is this information or disinformation? Have you seen this latest?
I've seen it. I have seen the headlines. To be honest, I haven't read much about it. Yeah, I'm sorry, I can't answer, but I have seen the headlines. I
Okay,
sadly
well,
haven't read up about it.
maybe
Peter,
I
I
can
have
just
actually had a conversation with someone about that. So there's some new concern about the pads not being organic enough in tampons, but
yeah.
people are looking at that.
If anybody wishes to follow up, there's a SASOG white paper come out. This follows some research done by a PhD student in Bloemfontein about EDCs in sanitary products, that's pads and Tampax. But in terms of the available evidence, there's no evidence to suggest that these are damaging or harmful. So in terms of the SASOG position, this is misinformation. So Steve, would you kindly thank our speaker for this evening, please?
Of course, yeah. Thanks so much, Joss. It's always great having you. You stimulate our thoughts. I always feel like we should have another hour or two to discuss a lot of the issues you bring up. I mean, you now started to talk about supplements. It's a huge discussion. And we could spend hours talking about it with our patients and with each other actually, and everyone's got a slightly different take on it. But you've raised a lot of issues. These are really important problems that we deal with on a day-to-day basis with patients. And I think you've given us a great perspective. And you're right. I mean, we often do feel like we little David's against Goliath with a plethora of information out there, and we often do feel often out of our depth. But you've absolutely, brought us down to, the facts, and we really appreciate, everything you've said to us tonight. So thanks so much, and
Pleasure.
look forward to further conversations, around these quite difficult issues. But thanks so much, and yeah, it's
Thanks
very
for
hot in
having me.
Cape Town. Yeah, I hope you've got a pool or something somewhere cooling down, and yeah, we'll see you again
Really
soon.
cold white wine, I think Jocelyn's prefers.
There we go.
All right, thanks so
Cool.
much.
Thanks very much.
Everyone.
Have a
Thanks
good
so
evening.
much.
Yeah, Chris, thanks everybody. Thank
Thanks
you.
so
And
much.
Okay, bye. Bye.
Bye.